Hello, everyone, and welcome to McGill Cares, a webcast series supporting family and informal caregivers of people living with dementia. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine and Dr. Serge Gauthier, Professor Emeritus in the Departments of Neurology and Psychiatry. McGill Cares is supported by the Amelia Saputo Community Outreach for Dementia Care. The McGill Dementia Education Program offers a comprehensive range of free multilingual resources to educate and support people living with dementia, family caregivers, healthcare students, and medical professionals. We invite you to visit our website at mcgill.ca/dementia, where you can access our educational guides, online courses, activity videos, virtual support groups, and more. We also have this amazing dementia companion guide that you can download for free. It's been translated in 14 languages, and copies are also available on Amazon. So today the topic is why insight can be lost in dementia, understanding anosognosia. This is probably one of the most important topics that I have wanted to bring forward to the webcast in a long time. And our guest today is Dr. Thomas Tannou. He is a geriatrician at the Institut Geriatrie de Montréal and an assistant clinical professor in the Department of Medicine at the Université de Montréal. Trained in France, he holds a PhD in neuroscience focused on self-perception and decision-making in Alzheimer's disease. His work sits at the intersection of geriatrics, neuroscience, and health technologies, with a particular interest in autonomy, judgment, and supporting people living with dementia and their caregivers through ethically grounded care. He's also a member of Quebec's Alzheimer Plan Advisory Committee and the Quebec National Advisory Committee on Ethics in Aging. Welcome to McGill Cares, Dr. Tannou.
Thank you so much for the invitation.
So we are going to be talking about anosognosia. It took me a long time to be able to say that word. Am I saying it correctly?
Yes, you are. Let's try to see if I say it properly in English,
Okay.
anosognosia.
Yeah.
This is part of the issue, is to make it understandable for people.
Maybe understandable. And every time I bring up the topic with families that I work with, everybody says the same thing. I never knew that. So let's begin by explaining what anosognosia is and how it differs from what we consider psychological denial, because a lot of people keep saying the person's in denial, but they're not in denial. They're suffering from anosognosia.
Yeah, let's start with the question of what is Alzheimer's. You know, we see Alzheimer's disease very often in general audience conversation as a disease of memory. But what does that mean? It means that in fact you have you decrease your capacity to learn new information. It's more a disease of memorization than a disease of remembers. And so if you have a decrease of new memorization, then it means that you lack capacity to remember new information. But part of this new information is yourself, your evolution. So in fact, you slowly lose your capacity to remember that you are losing your capacity. And so at some point, you don't remember that you don't know that you don't remember. So you have like this vicious circle where you forget, but you forget that you forget.
Okay, so let's begin with some of the most common symptoms of anosognosia.
I would say two different types of symptoms. The first one is the one that you mentioned implicitly when you say that people may question around denial, which is in fact to say, okay, we have like a conversation, and the older adult living with dementia may say, oh, I have not seen you since a long time, even if you came the same morning. But because he forgets then you have this conversation where, no, I am there, and this is part of the symptoms, but it's, I would say, visible because it leads to confrontation, where some other symptoms are more about inappropriate perception of your capacity. And so you may feel that you're able to do things you're not able to do anymore, or you're more vulnerable at doing it, like banking or like driving. And so you think you're able to manage some complex daily living activities, even if you're not anymore. And you may act, especially at the early stage of the disease, you may act without caregivers to drive you in, and it can lead to some vulnerability, to not say some issues, in particular in the topic of banking.
So what you're saying is essentially then it would cause people to take some really unnecessary risks, right? Like there's no logic, like there's no risk logic, right? They just do it. They just act and it could also cause people to act impulsively, I'm assuming as well.
Yeah, exactly. But I would say if we ask the people, this is risky, they will say no, because they don't perceive the risk because they think they're on control.
Okay.
So if I want to go skiing, yes, it may be risky, but because I know my capacity to ski, I will adjust my speed. If I don't adjust my speed because I think I'm okay, then I will take unnecessary risk. It's exactly the same here. With anosognosia, the fact is not to have a risky behavior, is to not know that you are currently taking a risky behavior, a risk. So if you don't perceive your own limitation, then you take risks that you don't perceive as a risk, and so you don't implement strategies to protect you to the risk.
Is anosognosia only seen in Alzheimer's disease, or can it be present with other types of dementia, like frontal temporal, Lewy body, vascular?
It's present in other type of dementia. It is more prominent in Alzheimer's disease, but also in frontotemporal dementia. It's less present in vascular or in Lewy body dementia, with the fluctuations that we know from the Lewy body dementia. But it's directly correlated with the memory, the encoding issue. If you don't remember yourself, then you don't remember your personal evolution. And so you are deeply sure that you are able to do things that finally you forgot that you're not able to do anymore.
And does everyone who is diagnosed with Alzheimer's disease have anosognosia, or does it mean that everybody will have it? Like, okay, are there some people that develop it and others don't?
It's not a 100%. Studies lack consistency because the symptom by itself is not well known and so well defined. But it's over 50% of people living with Alzheimer's that develop the symptoms. But we don't know exactly how much because of the name. Anosognosia directly come from neuropsychology and neurology sciences. So anosognosia is not used uh, out of this specific settings. So even if in first line care, or people don't use the word anosognosia. So we have different words, meaning that we have different scales, and so that in a scientific perspective, we don't have enough documentation of this phenomena.
Right, because I guess most of the words that would be used is the family would say, well, they're in denial. They're always
Exactly.
in denial. Maybe occasionally you would hear that they have lost their insight or lost their judgment, but I think most families will say, well, actually, there's two words. They'll say they're in denial or they're being stubborn, right?
Yeah, and this is important, and I realize I didn't completely answer to your first question with the difference between denial. And I would say that it's important to understand that denial, it's part of a natural process of acceptation of diagnosis or any case of any situation. But denial will evolve at some point. You will accept the situation. And as long as you think that people living with Alzheimer are in denial, then you try to convince them.
Mhm.
You want to prove, to make sure they accept the reality, then to be able to go on the right direction, which is not the case with anosognosia because it's not denial. You may have denial with anosognosia because you have such a situation where it can be difficult to accept the diagnosis and your current situation. But anosognosia is specific to the biological and clinical process of a neurodegenerative disease.
So based on that, so from a medical perspective, what exactly is happening in the brain that causes a person to genuinely lack awareness of their symptoms?
We don't 100% know because of what I said previously. It's interesting to know that at the beginning, the use of the term anosognosia was, by the medical definition, excluding the neurodegenerative symptoms such as Alzheimer's. It was more vascular when you had a stroke with hemi-negligence. It was where we were talking about anosognosia. So what we know is that anosognosia impact a lot of neural networks, but mainly including the memory part. And so as long as you have this in Alzheimer's disease, at least not necessarily strokes, but as long as you have these memory issues, lack of capacity to learn new information, it includes your personal evolution. And so this lack of personal, I would say even physical insight leads to the development of anosognosia.
So, as anosognosia appears early on in the disease, even sometimes before somebody is diagnosed with Alzheimer's, right? Because one of the biggest complaints or challenges that caregivers face is when you start noticing these false beliefs, accusations, or these certain behaviors or changes in personality, and you want to take the person to see the doctor, right? That becomes very difficult because the person, like I lived it with my mom, says, well, there's nothing wrong with me. Why should I go see a doctor? And so then when you're trying to reason with them and say, well, I've noticed some changes in your personality or memory, that they are absolutely in denial, right? But it's not denial, it's the disease that is making them that way, right?
Yeah, which raises the importance of early diagnosis. Because in fact, before reaching that stage, very often people have memory complaints. And they try to say, oh, but we may try to say as family caregiver, oh, this may be your age, or it's not, it's maybe because you're tired, or yes, the winter is long, so you just need some vitamins and so on. But no, or maybe yes, but at least try to deal with making sure that it's not the beginning of a neurodegenerative disease, and don't wait for the moment where it's so obvious that you don't need a physician to do the diagnosis. And no, please go.
No, this is where I was going to say, and this is where I think that there needs to be a lot more education to the public that the early symptoms of Alzheimer's disease could start with a significant change in personality, right? Because
Yeah,
people often think, dementia is about memory loss, but it could start with a significant change in personality, like false accusations, false beliefs. Like I'll tell a story. I tell this a lot when I do my public speaking. So my mother was diagnosed with Alzheimer's disease in 2006. But oftentimes the seeds of the disease are planted way before that, right? And once upon a time, when my son was little, I had a cat. The cat was 4 years old, and I went away for the weekend, and I brought my son to stay with my mom, and I brought the cat. My mother loved this cat. 3 days later, I come back, I have my son, and there's no cat. And I said to my mother, "Where's the cat?" And she says, "The cat is dead." I brought the cat to the veterinarian, and I put the cat down. And I was horrified. I said, "What? Like, why would you have done something like that?" She said, "Because the cat started to scratch the wallpaper, and your father was getting upset." And I was horrified. But a few years later, I had a bit of an aha moment and said, "You know what? That's when it began," right? Because there was no logic behind that decision at all. And when I was trying to reason with her, like, how could you have gone and euthanized my healthy cat? And so there's oftentimes these behaviors, these false beliefs that somebody's cheating or stealing, right? Which becomes so difficult for the family members, but they don't realize that this is part of the disease.
Yeah, and thank you for sharing. And I feel sorry for your cat,
Yes.
uh, and for you and your son and your mother on that situation. But um, you're so right. It's really important to consider that Alzheimer's disease is not a disease of the memory. This is true on the basis of uh, neurology. And this is 100% true. We don't say mistakes when we say that, but to understand the process, the behaviors, we should not consider memory as a first symptom because this is not true. Uh, Memory is more, as I said previously, it's more about learning new information than remembering others. And so what is impaired is this capacity to learn new information. But what is the purpose of learning new information? Is to adapt to new situation. So Alzheimer's disease is more a disease of adaptability than a disease of memory.
Mhm.
And so if we consider this vision of adaptability, then it is uh, easier to understand the early symptoms. And even if the cognitive tests that you may do may be normal or subnormal, if you have an evolution that shows that you are changing your behaviors, please go and go see a physician, a specialist. And we today have capacity to look at biomarkers, to look at your brain through MRI, to do lumbar puncture or even blood test right now, even if sensibility and specificity are not 100%. So just be careful and based on that. But do all the examination you need to do to clarify the diagnosis and to better anticipate the evolution, especially because of the late consequences of anosognosia that will lead to potential conflict on the anticipation of care. The sooner
And
is the better.
And I think we talked about it earlier on, but I think I would like to just expand on that more. I mean, there are some serious safety issues that could impact, like, for example, managing finances, because it's in the early stages and a person still feels that they could manage their finances, they could fall victim to these financial scams and romance scams. And because when you're cognitively healthy, hopefully you think before you act, right? But when people are getting these fraudulent emails or financial errors or phone scams, they're not able to manage their finances, and it causes so much stress among families because you can't go back to the bank and say, well, they just lost $50,000 because of an error, but it was that so could you elaborate a bit more on all the other impacts it could have as well on
Yeah,
safety?
maybe first on that point, you mentioned that um, without Alzheimer's disease, you will think before acting, generally speaking. um, what is interesting regarding self-awareness impairment, which is the broader term when we try to talk about anosognosia, or like I would say self-awareness impairment is broader, is that even after the mistake, you may continue to try to insist on the fact that this was not a mistake. No, I was sure this is not how you should act. So this is also an early sign of impairment in your cognitive process. This shouldn't the capacity to reflect on your own action and to have like a critique of your own dynamic. It's part of the normal decision-making process, the feedback.
Mm-hmm.
And so if you have an impaired feedback, this is part of the misjudgments that you can have at an early sign of self-awareness impairment. And this led to the question of safety, because you may not consider your behavior as unsafe, but because you don't have this feedback regulation, then you don't perceive your own dynamic, and so you will continue in the same pattern of action that creates the situation that puts you in a vulnerable situation. So at early stage, this is more where we have this safety issue. But if we go later on, the safety issue is not exactly the same, but it's the same process that created. But early on the evolution of the disease, when you have more daily living activities issue, because of the need for support, caregiver will argument to say, okay, we need to implement some social support, some nursing help or anything. But this means changing daily organization. And because of Alzheimer's disease, not even anosognosia, because of Alzheimer's disease, as a disease of adaptability, as we mentioned earlier, the person living with Alzheimer will see the introduction of modification as a safety issue. Because the safety, if you have disease of adaptability, the safety is to not have changes. You need to have everything stable, because new things, instability means adaptability, and you're not able to adapt. So you have like a conflict of value between the caregiver perception that say, okay, we need to implement strategies, and the older adult perceptions that say, okay, we need to not implement strategies. So for that, we need anticipation, because both are on the same page. They talk about safety, but internal safety means stability, while external safety means changes. And that's how it starts to be difficult.
Yeah, and I think, I mean, what I always try to assure the families that I'm working with is that as the disease evolves, because anosognosia is so present in the early stages, because the person is still very communicative and verbal, but as the disease evolves into the more middle stage, where now it starts impacting more a person's activities of daily living and they start to be less communicative, the anosognosia isn't as present because they're having more and more hard time expressing themselves, and they at some point, like you say, they start adapting to the fact that they have to have some help, they have to have physical help. But it's very difficult in the early stages for families, because they are constantly getting into confrontations or being falsely accused of not being there, not being enough, cheating, the stealing. And I see, you lose your patience, right? You lose your patience, and it can cause serious arguments and conflict that, if not well monitored or not well moderated, the verbal could become physical on both parties, right? So, what would be your advice to family caregivers to try to like deal with this anosognosia? Like, what would be some strategies?
The first one, and I'm sure you say this in your education approach, but the first one is there is no need for confrontation except in case of real emergency. But um, otherwise, just don't confront. I would like to remind to everyone that we all have this first reflex, sorry, to consider the responsibility of others if something happened to us. Um, we were discussing previously, and I told you that when I came home yesterday evening, my children were, it was close to the super and some excitement at home. And so I just put my keys close to the door, which is not their usual place. And I just forgot after that. And this morning, when I was ready to go and late, I just look at my keys on the key box and no keys because no one put my keys from the place I put my keys yesterday to the right place. And what was my first idea? It was to ask my wife and my children, what have you done with my keys? But no one have touched anything. But because my hippocampus are working, I was able to say, okay, hold on. Let's remember what happened yesterday evening. And I will mentally replay what happened yesterday when I came home. And so I will find my keys. But if your hippocampus is not working well, then you will stop on the first idea that we all have. And so you will have this idea that someone else put your things out because you don't remember what was your occupation the last time you have done something with your keys or glasses or anything. So this is a normal way that human brain works, and it's just that the second step is not working in Alzheimer. So we focus on the first one only. So once we get this, we need to support people living with cognitive impairments within the process of remembering where they have done, where they have put their things. And so we need to remember that, and that's why Alzheimer's disease is not so much a disease of memory. It's still possible to learn things on the evolution of Alzheimer. You can learn strategies. You can learn routines. And so implementing some routines to make sure that things are always on the same place with, sorry, I'm looking for the English name for that, errorless strategies.
Yeah.
It's possible to learn new routine and new strategies with this type of learning that comes with OT strategies and so on. But you can learn how to implement routine. You can also have visible marks that things have been done, like a notebook where you write. People often use a calendar to remember things in the future, but not necessarily things from the past. So like having a daily note information. Okay, it's 11. I just received a phone call from Paul. Paul is fine today. Great. And, like that, if you want to go back, you have all this information. So if you cannot retain information, write it and go back to it.
And I think what's important for caregivers as well to know is that you shouldn't be taking anything personally. And that's really, really hard because anosognosia is an illness. And the person, there may be false accusations or telling you you're never there, but if you take it personally, it could cause a lot of pain and conflict. And I see so often that, the accusations happen, the caregiver or the family member is trying to reason with the person. It goes on and on and on, but then the next morning the person wakes up again with the same accusations, right? And so to not take it personally. And I also think that it's all about, like you said, it's about picking your battles, right? So if what the person is doing and what the person is saying isn't hurting anybody, it's not hurting themselves or hurting them, let them be. If they're telling stories about the past and if you're continuing correcting them, I mean, you're just fueling the fire. Just join their journey. Let them be. If they're crossing a red light and they have a risk of hurting themselves, absolutely, you need to intervene. But oftentimes this confrontation starts because I feel like the caregiver or family member is having a hard time adapting and evolving with the illness, right? And you really have to, because what's happening today is not what's going to happen in 6 months. But this conflict could it could be so exhausting and so overwhelming and really lead to sometimes physical aggression because the person living with dementia could get so angry and throw cell phone, throw remote control at the family. So you have to really, pick your battles. Like you say, is it really worth it? Like, is it worth the
It it
conflict?
it's so important what you said. It's very important to say it and say it and say it again, because the companionship to live with someone living with Alzheimer's disease can be exhausting. We are talking about a neurodegenerative disease. We are talking about an evolving disease. And so sometime in my medical consultation, I said to patients that I have not seen since, I don't know, 6 months, for example. And if I see stability, then I say, okay, this is a good news, because stability regarding a neurodegenerative disease means improvement
Mhm.
comparing to baseline, because 6 months after baseline is done, that the previous one. So if you're stable in a slowly decreasing condition, it means that basically you improve.
Mhm.
And we need to remember that stability is not what happens in Alzheimer's. It evolves. And so caregiver has to be ready for this evolution. We need to have more care to caregivers. We need to have more psychological support for caregivers, because it's really difficult. But caregivers need to learn to let things go and to remember that the right word is not about um, what is true or what is false,
Mhm.
because um, because of the memory issue of people living with Alzheimer's, they may imagine things that for them is 100% true. And sometimes it is just 5 years ago or 10 years ago. But if, about food, for example, if someone say, hey, yesterday evening I had, I don't know, fries and chicken. No, you didn't had fries and chicken because I brought you beef. Okay, but is it the point?
Mhm.
You
So that's why,
know,
like, join their journey. Who cares, right? Let's say if you keep correcting them, like, who cares?
why do they say that they had chicken and fries? Because they remember, sometimes I say to some patients and families that I don't know if I will be able to do it along all my career, because it does not exist anymore. But this um, audio or VHS that we had on an older time before Netflix and so on. Um, if if you consider that there is like a band that is currently recording live, and at some point, because of Alzheimer, you stop recording, does not mean that you record blank, just means that you stop recording. And so if you go backward for 20 seconds, you will have music or people talking. But maybe if you stop to record 3 years ago, what you will have on the band will be 2 years ago minus 20 seconds. So it's exactly the same in Alzheimer's. Uh, it's not like recording blank and you can say to people, okay, remember that you don't remember. No, because of anosognosia, you cannot. So it's like their yesterday start from a certain moment where the recording process stopped to work. And so, yes, there is something on the band yesterday evening. It's just not your yesterday.
Mhm. So I have time for one more point, and I would like your thoughts on what I'm about to say, because I say this to families that I work with a lot. You know, sometimes because of the anosognosia, a person has failed to go and have a medical evaluation, right? Because they say the person is refusing. And I cannot reinforce enough the importance of seeking a medical evaluation because number one, they need to be seen by the doctor and be evaluated. There may be other behavioral issues or moods that may appear, and the doctor can prescribe some mood modifying medication. But as a result of anosognosia, at some point, the family may have to assume all the legal and financial and all of those administrative important documents, etc. And the only way that a family member can assume that is by having the medical evaluation by the doctor. So you can't say, no, I'm not going to bring them. I'm afraid to bring them. Because if you don't bring them to be evaluated and all these financial errors start happening and all of everything else, the family will have no recourse. You must be seen by a medical specialist.
I I mean, by definition, as a medical specialist, I mean, I 200% agree with that. But I would add two things. The first one is to come back to my previous point about early diagnosis. Why early diagnosis is because it led time to negotiation. When we received medical consultation requirements for assessment of incapacity for legal matters, it just sometimes it's just too late. We have to because obviously there is some issue with money and it's indeed necessary to do it, but it will be painful for everyone. If we take time then we have time for negotiation and we can have a first consultation saying, hey, we are just here to say hello, to understand you, and without doing anything, or to say, what can I do to help you? And, to implement slowly different strategies because we can imagine physicians as, only medical prescriptors for medication. But uh, first, it's important to know that for now, we have different type of medication, including new medication for early stage of Alzheimer's. So it's very important to remember that the earlier is the better. But even then, on symptomatic management, there is not only medication, even if medication is useful. There is also medical prescription for OT, for physio because of potential mobility disorder associated with, for psychological support, but also different strategies, for swallowing rehabilitation, if any. So all this package with medication, adjustment of other type of medication, also rehabilitation and legal and social and anticipation, the anticipated med is also part of the discussion sometimes. So just all this continuum takes some time to have time for negotiation and improvement of relational quality of life, trust, and being incapacity to support all along the continuum of Alzheimer's disease. But because of anosognosia, we need to build this relationship in a time frame that includes capacity for negotiation.
This is such an important and complex topic, and I hope that people today at the end of this webcast realize, oh my gosh, now I understand why they're behaving this way, or I understand what this is. Like what, I'm sure many people have been kind of like dealing with all of this and without much information. So, Dr. Tannou, thank you so much for coming today and sharing your expertise and insights on anosognosia.
My pleasure. Thank you.
So this webcast is an initiative of the McGill University Dementia Education Program, which is funded by private donations. If you would like to make a donation to our program or for more information about all of our free resources, please visit our website at mcgill.ca/dementia. And you can also sign up for our newsletter to be informed about upcoming webcasts and other very interesting initiatives that we have going on. So thank you very much for joining us.